Good afternoon, Mr. Chairman, ladies and gentlemen. Thank you very much for this prestigious for this time to talk at this prestigious prize session. This work was conducted in conjunction with the University of Southampton and the University of Liverpool, whilst I was undertaking my PhD there. In February 2015, the Fitful Surgery Consortium, which is based in Southampton and in Liverpool, has published this paper in the British Journal of Anaesthesia. We were the first group to objectively measure the harmful effects of neoadjuvant chemoradiotherapy on physical fitness in locally advanced resectable rectal cancer patients. We were also the first group to objectively improve and instigate a prehabilitation program and objectively measure and improve physical activity and physical fitness after neoadjuvant cancer treatments prior to major surgery. This, however, does not give us an insight into the mechanism of harm or benefit with chemoradiotherapy and exercise. This randomized control trial has been set up to do just that. In vivo skeletal muscle function using MR spectroscopy has never been attempted in any cancer cohort before. As you can see, this is one of our rectal cancer patients about to enter the bore of a 3 Tesla MRI scanner with a phosphorus coil strapped to his right leg. He will be performing timed exercise sessions within the MRI scanner whilst being scanned. The main objective of this trial was to look at in vivo mitochondrial function in a large peripheral muscle, namely vastus lateralis, as you can see, without the need of an ex vivo mitochondrial or muscle biopsy. MRS is a validated technique that obtains resonance signals from specific metabolites. In this case, changes in 31P nuclei, which are found exclusively in the mitochondria. These are inorganic phosphate, phosphocreatine, and ATP. This yields a quantitative measure of ATP turnover and mitochondrial energetics, which are displayed as a function of frequency. This is a compressed dynamic 31P MRS time series in one of our patients in the whole exercise component. This is PCR that decreases with exercise and improves as exercise stops. This allows accurate calculation of the kPCR, or the phosphocreatine recovery time constant, which is a validated surrogate marker of mitochondrial function in vivo. So we set out to test the hypothesis that neoadjuvant chemoradiotherapy would impair in vivo skeletal muscle mitochondrial function as measured by kPCR, and that exercise training would improve fitness and mitochondrial function. We included MR-defined circumferential section margin-threatened rectal cancers, all of which T3N+. All patients were WHO performance status less than 2. We recruited 12 patients, all of which had a cardiopulmonary exercise test or CPET test, which observes objective markers of fitness, and an MRS scan at baseline. They underwent a standardized course of long-course chemotherapy for 5 weeks. They were randomized in a 1:1 fashion into an exercise group and a control group. All patients underwent similar interventions, including a CPET test and an MRS scan at week 0 immediately post-chemotherapy, a CPET test at week 3, and a final CPET and MRS scan at week 6. This is the exercise program that was implemented. The exercise group was conducted as a supervised in-hospital interval aerobic training program. This was conducted 3 times a week for 6 weeks. It was prescribed and tailored to individual patient's fitness post-chemotherapy. The adherence to this exercise program was 89%. These are baseline demographics, as one would expect for an elderly rectal cancer cohort. There were no differences in baseline demographics, no differences in BMI, spirometry, MR-defined fat-free mass, hemoglobin, or tumor characteristics within the whole of the trial. These are some results. So when comparing whole body fitness measures measured by CPET, this is a graph of oxygen consumption at lactate threshold throughout our trial at our 3 time points. As per our previous publications, we observe a statistically significant decline in physical fitness, which is acute during the first 5 weeks of chemotherapy. Patients declined by an average of 2.3 mL per kilo per minute, which is statistically significant. The exercise group dramatically improved by 3.4 mL per kilo per minute, as compared to the control group, which unfortunately lost their physical fitness even further. A direct comparison between groups at week 6, correcting for differences at week 0, show an improvement by 3.85 mils per kilo per minute, which was found to be statistically and clinically significant. When comparing these to mitochondrial function, a stark similarity emerges. Mitochondrial function declines with chemoradiotherapy between baseline and week 0 post-chemoradiotherapy. This dramatically improves by 71% in the exercise group, as opposed to a marginal improvement by 20% in the control group. Again, a direct comparison between groups at week 6, correcting for week 0 differences, show a statistically significant difference of 0.66, which was found to be, which was also deemed clinically relevant. So in conclusion, Mr. Chairman, ladies and gentlemen, this work validates the already described changes in fitness with neoadjuvant chemoradiotherapy and rehabilitation. These data show novel, potentially clinically relevant findings in that neoadjuvant chemoradiotherapy is associated with impairment in mitochondrial function, and tailored exercise will significantly improve mitochondrial function in vivo. A potential mechanistic link driving the changes in fitness can be hypothesized, so tailored preoperative interventions could be planned. These are my acknowledgements. Thank you.
Thank you very much.